multiple sclerosis. It is characterized by demyelination, of both CNS and PNS. That is, it will lead to demyelination both in central as well as peripheral nervous system. Now, one more thing, why I am laying stress on this word? Because we have one disorder so-called Guillain-Barré syndrome, what we call as GBS, that is primarily involve the peripheral nervous system. Guillain-Barré syndrome is usually doesn't involve CNS. That's one point that you have to understand right now. Remember, in both the disease, the basic pathology is demyelination. Okay. Now, when you talk about the pathological triad of what we get in this, both CNS and PNS, is inflammation, demyelination, and gliosis. This is a triad. Now, before I proceed further about multiple sclerosis, I would like to discuss some basic concept about what the disease is. Then you will understand better, much better understanding of the subject will be there. The basic concept goes like this. Let's talk about normal anatomy of a nerve. This is a gray matter, cell body. This is the axon. They are the dendrites, and here is the myelin sheet. And the myelin sheet is made of Schwann cell. And now, in a myelinated fiber, these are nodes of Reneviers. These nodes of Reneviers. And due to these nodes, they have a saltatory conduction, and that's why in a myelinated fiber, the conduction velocity is very, very fast. Now, one more thing, cell body of a nerve always lie in the gray matter or in a ganglia, and the fiber, they lie in the white matter. This is universal truth. Now, a question for you. You can stop the video after listening to a question and write down the answer. The question is, all the nerves, cell body lie in the gray matter or ganglia, fiber, they lie in the white matter. To this rule, there is only one exception. What is that exception where the cell body does not lie in the gray matter? Write down the answer. Well, I'm sure you have written the answer. Answer is olfactory nerve. In olfactory nerve, the cell body lie in the nasal mucosa. This is something exceptional that you should know. So we come back. So we have understood that cell body lie in the gray matter, and the fiber, all fibers, whichever, whether it is myelinated fiber or unmyelinated fiber, they lie in the white matter. And I told you in this disease, the problem is demyelination. Now, how the nerve will appear? Now the nerve will appear like this. So as the myelin sheet has gone away, that means this saltatory conduction will be not there. So now, what will the effect? There will be reduced conduction velocity. You understood why? Now one more thing, one extra point that you got to understand. As I told you, it's a disease of the white matter, and this myelinated fiber, all are involved. That means patient will have motor manifestation, sensory manifestation, and patient may have bladder manifestation, cerebellar features, etc. By and large, all types of manifestation will be there, about which I will be talking to you soon. Now, if everything is there, Now you are going to ask me questions. Sir, tell us something which does not happen. Now, feature which do not happen, which is much easier for you to remember, which are not the feature are seizures, Parkinsonism, and speech aphasia, that is Broca's aphasia and Wernicke aphasia, which I am sure which are due to Broca's aphasia is a motor aphasia and Wernicke aphasia is a sensory aphasia. These three things do not happen. Okay? Well, why they do not happen? Because these are gray matter diseases. So I hope I have simplified your subject of multiple sclerosis to a great extent. With this background, we move further. Now, one more characteristic feature of the disease is disseminated in time and space. This again you need to understand. For example, patient has come to us with hemiplegia today. And most of the time, what I told you by now, the problem is demyelination. I can show you a figure. This is a normal nerve, myelin sheet, and here the myelin sheet is broken, and that's why you can see that conduction velocity is little slow down. Okay, it's a broken saying. Now, one more thing. The good thing about the disease, the myelin sheet which is broken, it recovers. It can become like this. So that means patient will fully recover. But problem is, again the disease can occur, and this. But one more thing. So this is disseminated in time. Normal, abnormal, normal, abnormal. But one more thing. It is disseminated in time and space also. What do you mean by this? At one time, patient may have paraplegia with some cranial nerve palsy, and you cannot explain with a single lesion. Paraplegia also may be seventh nerve palsy, or of course, I'm talking of motor paraplegia. I'm talking about with cranial nerve palsy is usually not seen. Maybe at one time patient has hemiplegia with some peripheral neuropathy also. The different types of which we cannot explain by pointing a lesion at single place. This is what we call as differentiated in time and space. This is the classical feature, right? With this background, we move further. Now, what are the areas in the world it is distributed? You can see more in the extreme north part. Why? What is the reason? What the latest update has come up? If you can see, it is less near the equator. What is the difference between the two in the location wise? They have less sunlight. And there is plenty of sunlight. So now what the new theory has come up that perhaps vitamin D deficiency plays a very important role in the pathophysiology of multiple sclerosis. This is the reason why it is more common in extreme poles. Well, we move further. Now, there are certain disease patterns are there that you got to know. First of all, we have a RRMS, what is known as relapsing, remitting multiple sclerosis. Suddenly attack occurs, patient become all right, again relapse occur. So we have relapse and remitting. What's the meaning of relapse? Disease has increased. Remission means disease has gone down. This is a term that we use, generalized term for any medical illness, relapse and remission. And remember, in this case, usually it may or may not leave any permanent deficit. This is one pattern. Then second pattern is PPMS, primary progressive multiple sclerosis. Disease occur and it is increasing. Okay? It's progressive from onset and no relapse or no remission. It's always increasing. There is no remission at all. It is always increasing is primary progressive. Then we have one more entity, so-called Secondary progressive multiple sclerosis, SPMS. Initially, patient come as RRMS, relapse remission. But after some time, it start having progressive. That means it's a combination of the previous two which I discussed just now. And finally, we got progressive, relapsing multiple sclerosis. There is an increase, progressive. Suddenly there is much more sudden relapse, but again come down and increases like this thing. This is progressive relapse, relapsing multiple sclerosis. So there are different type of pattern of progression is there. Now, what are the risk factor for this? First of all, I told you, it's a disease more in females, usually around 20 to 40 years. Then, family history may be there. It's again, if there is somebody in the family, it is a it is a risk factor. Then, HLA-DRB1 gene, this is a presence of reactive T lymphocytes. Autoantibodies, again the myelin oligodendrocyte glycoprotein, so-called MOG. Then some HHV type 6 and chlamydia. Pneumonia. They are the risk factors. Well, which criteria we use to diagnose? McDonald criteria. And now it's considered as a gold standard in the diagnosis. You just got to know the name. There's a huge table is there which you don't need to learn, but just remember which criteria we use is McDonald. Now, what are the clinical features of this case? Fatigue is one of the most common and early manifestation. And due to fatigue, patient may have some gait disturbance. Of course, there are many more reasons of gait disturbance because there may be involvement of pyramidal tract or maybe sensory or maybe cerebellum also. But fatigue is one of the most common manifestation. Now, pyramidal sign, as it happened, there will be increased tone, increased deep tendon reflexes, plantar will be upgoing, the feature that we see in any motor neuron disease or pyramidal tract lesion. Retrobulbar neuritis is one of the early features. Now, what happened this? It's a very most frequent type in adult, and the classically, in the initial stages, optic disc appears normal. Okay, why? Because there is demyelination in the optic nerve behind the disc. With the result, as the disease is behind the optic disc, now standard line, what is written in the books, first you write down the sentence, then I'll tell you the meaning. The standard line of this is patient cannot see, doctor cannot see. Now, what is the actual meaning of this? For that, we have to learn the basic. The basic goes like this. Well, let's learn how is the optic tract. This is the optic eye and optic nerve. And this optic nerve goes, and ultimately, I hope you know, the center of vision lies in the occipital lobe. Same here also, it goes like this, right? Now, let me presume, and this myelin sheet is there. Second nerve is a myelinated fiber. Myelinated fibers are there, right? Now, what happened? Demyelination occurs behind the disc. So, well, as the pathology lies behind the optic disc, When the doctor examines the fundus of the eye, he cannot see. He will find fundus to be normal. But as the myelin sheet is not there, that will hamper the vision. The patient cannot see. So right, so I hope you understand the meaning of doctor cannot see and the patient cannot see. This happens in the early phase, so-called, remember, it's talking about retrobulbar neuritis behind the eyes, right? Well, later on, patient get optic neuritis. Usually symptoms are monoocular. This is very, very important. Bilateral is very, very rare or uncommon. So it leads to what? Acute onset of monoocular vision loss with central scotomas. Now, and that will lead to what? Decrease acuity. Vision will be reduced. And what the clue to this thing, that it is optic neuritis? Eye movements are painful. That means you ask the patient to turn around like this, the way I am moving the eye, patient will have pain in the eye. So eye movements are painful. And when the patient sees a colored thing, it looks like washout color. Washout color. What do you mean by washout color? Look at these photographs. They are photographs of same object. Now this is normal, very clear picture. And this is as washout color is an old picture, something like that. The term they use is washout color look like appearance, right? Now, in this patient, one of the earliest manifestation is relative afferent pupillary defect, RAPD. It is one of the earliest manifestation of the disease. And in the advanced stages, optic atrophy will occur. But just to remind you, in the very beginning state, most of the time, fundus examination is normal. Now we talk about pulph-frick effect. Now, what is this? Again, you got to understand. First, you write down defective depth perception, what we call as pulph-frick effect. Now, what is this and why the basic? Again, we learn the basic concept. Well, it is remember, most of the time in MS, it is single optic nerve is involved. And let's go for the same diagram. This optic nerve, and here it is myelinated fibers are there. And here demyelination. And since suppose we see one impulse, they see one object. Now, in this nerve, it will reach very fast to occipital lobe. Why? Saltatory conduction, rapid conduction velocity. But here, from this eye, it will go very slowly. So it will reach fast, it will reach much later. So that means patient is looking at same object, but they are not coming together, they are coming, so a depth difference will be there. And this will be what is called as pulph-frick effect. I hope things are clear to you. Now, how we really diagnose optic neuritis? By MRI of the orbit and the brain. You can see this demyelination is there. Now, what else we see in multiple sclerosis? One of the classical or characteristic feature is internuclear ophthalmoplegia. It's a characteristic feature of MS. First, we learn the text, then I'll show you photograph also, and then you'll understand better. It's a disorder of conjugate horizontal gaze. This point should be noted very clear. Horizontal gaze, and which nerve is involved? It is a sixth nerve, lateral rectus is involved in abduction. And for adduction, third nerve is involved. Okay? And in this, there is damage to medial longitudinal fasciculus. we should understand what the structure is. Again, we learn the basic concept. The basic concept is that we know very well that, like suppose I'm looking at right side, my lateral rectus is getting used and sixth nerve, and my this left side it is the medial rectus supplied by third nerve. Now I'm looking at left side, lateral rectus, sixth nerve, medial rectus, third nerve. So we have different muscles, three nerves, third, fourth, and sixth. They supply different muscle, but the eye movements are exactly coordinated. It's a pinpoint, exact computerized movement is there. Why? That means there is something which is connecting these three nuclei, third, fourth, and sixth. They are united by medial longitudinal fasciculus. That's the reason why the two eyeballs have a perfect coordinated movement is there. Now, in internuclear ophthalmoplegia, the lesion occurs in medial longitudinal fasciculus, ipsilateral. So, affected eye on the same side is not able to adduct. Okay? The contralateral eye abducts with the nystagmus. The unilateral MLF lesion can occur with lacunar stroke in pontine artery distribution, but bilateral medial longitudinal fascicular lesion occurs only in multiple sclerosis. Now look at this picture. So here we can see, this is the baseline. You ask the patient to look at right side, they can see, but now you ask the patient to look at left side. This eye which is affected, abduction is possible. But you ask the patient to look at this side, adduction is not there. This is the one what I want to inform you regarding internuclear ophthalmoplegia. I hope you understood the basic concept. What else are the features in multiple sclerosis? Patient can have sensory symptom, paresthesias, numbness. Impotency is a late feature. It's not a very early feature. Ataxia, this can occur due to cerebellar lesion. And if cerebellar lesion occur, what type of gait we get? You get drunken gait we get in this patient. Bladder dysfunction, it's there, it is seen in around 90% cases. But here I like to inform you something extra H. Just now, a couple of minutes back, I discussed that in Guillain-Barré syndrome also there is demyelination. But remember, bladder dysfunction is not a feature of Guillain-Barré syndrome. But in this, it is there in as high as 90% cases. How patient can manifest? Patient can have atonic bladder. That means there will be urine retention or urgency. Patient cannot hold the urine. He has to rush to toilet to pass urine. Hesitancy, that there is some obstruction-like feeling is there, or incontinence, urine keeps on dribbling. So they are all what can happen in a case of bladder dysfunction. Now heat sensitivity. Symptom increase after a hot bath. Okay? Whatever problem patient has, the patient find it is when after the bath, when patient comes out of the bathroom, symptom have increased, and this is known as Uthov sign, Uthov phenomena. It is considered as negative conduction abnormalities. Then we have one more, so-called Lehermit sign, so-called barber chair sign. What is this? Well, when we go to barber for haircut, what we do? What he does, he will bend our neck forward. Okay, we all do. Rather, he will get it done, we do, and then that's how he does the cutting. But in this patient, when the patient bends the neck forward, a current-like sensation goes in the limbs, upper and lower limb, and this is known as barber chair sign. Okay, and this is also known as Lehermit's symptom or Lehmann sign also it is known as. And this is considered as positive conduction abnormality. Now a question for you. Stop the video after listening to question, write down the answer. Tell me, in which other condition where we get Barber chair sign other than multiple sclerosis? Well, I'm sure you have written the answer. Answer is cervical spondylosis. Barber chair sign is seen in this condition also. This was extra knowledge for you. Now, there are certain paroxysmal symptoms, brief and stereotypic tonic, spasm, dysarthria, ataxia, diplopia, paresthesias. Trigeminal neuralgia is a feature where there is intense pain in the distribution of trigeminal nerve, especially mandibular and maxillary division. Facial myokymia, continuous twitching of small band or strip of muscle that gives a undulating or ripping appearance on the overlying muscle. And typically what they say as a bag of worms appearance, because of twitching of these, some waves pattern are made in the skin as some bag of worms is there, worms are moving and they are creating some movement like worms movement. Vertigo, especially when brain stem is involved. Memory loss is a late feature. That means dementia is not a feature, but depression is very common because patient is really, at times patient may be really handicapped and they have a increased suicidal tendencies. Now, patient has come to us, we are strongly thinking, and remember, one of the classical picture, in fact, whenever you see any case of neurology, never forget to ask one question, which is $1 million question. Had you any deficit, any neurological problem in the past? Any illness which is related to CNS? The answer is yes. You should strongly suspect about multiple sclerosis. Okay? Well, suppose you are getting one case to whom you suspect multiple sclerosis, or even patient coming to you for the first time where you examine the patient and you cannot locate single lesion which can describe his illness, you think about multiple sclerosis. So what are the best initial tests? MRI is the best initial test. And if a question is asked to you, which is the most accurate test? Again, answer is MRI. So that means beyond doubt you will talk about MRI. CT scan is not of no use in this diagnosis. So what we get in MRI, you get white matter inflammatory changes around the perimedullary veins, ovoid lesion, longest axis perpendicular to corpus callosum, and what else you get in these patients? You get demyelinating plaque. In the juxtacortical white matter, periventricular white matter, corpus callosum, and callosal septal interface. Now you can see a beautiful picture of plaques, and we also get, this is around the ventricles like what we call as Dawson finger sign on MRI. Evoke potential are again one of the diagnostic tool, and we can use visual or auditory evoke potential. Let me explain to you what the basic principle, the thing same which I discussed earlier, optic nerve, this, and if you, and this the myelinated fiber, and this demyelination. You see, you show a light, it will reach very fast. You show a light here, it will reach slow. So they are, that means there is a difference in the perception in the occipital lobe. This is what we have discussed earlier, is so-called visual evoke potential V2. As far as CSF examination is concerned, cell count is normal, and even the protein, it's normal. Traditionally, you read any book, every book they write in in MS, you get cyto, albumino, dissociation. I'm also saying the same thing. But it is not the albumin level which is raised. That protein remains, albumin remains normal. What increases is Ig, oligoclonal band. Oligoclonal bands. They are increased. In particularly, IgG are increased. That is the idea of so-called cytoalbumin dissociation. It's not a very specific test for multiple sclerosis, but it really helps on diagnosis. When suppose clinically you are suspecting a case to be of multiple sclerosis, but MRI is not the classical picture. A lumbar puncture should be done for CSF examination, and now oligoclonal band are there in 85 to 95% cases of multiple sclerosis. Right? But remember, in the CSF, opening pressure are normal. Remember, opening pressure are increased in normal pressure hydrocephalus. Proteins are normal. Protein here, what I mean to say is albumin. But just to recall you, very high protein level are seen in TB meningitis. Cell count are normal. Cell count are highly increased in pyogenic meningitis, where neutrophils are increased. In TBM also, where lymphocytes are increased. But in this, they are normal. Now, what are the poor prognostic factor for a case of multiple sclerosis? Older males. Number 2, motor symptom at the presentation. Patient having multiple relapses. Patient having early relapses. Patient having multiple lesion in MRI. If plenty of lesions are there, that means there is more and more scar is there, and that is bound to have poor prognosis. Well, how to treat a case of multiple sclerosis? Patient come with acute attack. Then the drug of choice is always glucocorticoids. Which drug we prefer to use? We prefer to use pulse dose of methylprednisolone. Advantage, it shortens the duration of exacerbation, and it is the best initial test. What else we can do? We can do plasma exchange. Once the patient is controlled, at the same time we start prophylactic drug. Which prophylactic drug we use? And now, what is the need of prophylaxis here? Remember, the disease course is relapse and remission. So we give, usual drugs that we give is methotrexate, cyclophosphamide, and azathioprine. Now, I tell you how these drugs are used. Well, we are starting with steroids. These drugs are also started immediately because they take some time to act. Their action never start immediately. So initially stage we are giving methylprednisolone for pulse dose. Later on we can switch over to oral steroid for some time, and for a couple of weeks. By the time these drugs start, then we gradually withdraw the steroid. Why can't we continue steroid for a long time? Because steroid have a long time side effect like diabetes, hypertension. This pattern is almost true in wherever we are if we have to use immunosuppressive therapy. Now, what are the newer drugs for prophylaxis? The newer drug is interferon beta 1A and 1B. It's one of the most widely used drug as a prophylaxis. It's a very effective drug, and the main thing is it's a very slow drug. Okay, it doesn't have much of a side effect. It's a wonderful drug, less side effect, hardly flu-like symptom may be there. Second drug is glatiramar or mitoxanton is other drug. Then natalizumab, something very interesting. This is one drug which we use for multiple sclerosis, which is a demyelinating disorder. but one side effect, this drug itself can lead to demyelination. Alemtuzumab and fingolimod are the drugs that we use. And other drug is triflunomide and dimethyl fumarate, and we also use cladribine. They are the newer drugs that we have used, but by and large, most commonly drug used is interferon beta. Now a question for you. You can stop the video, write down the answer. We are using cladribine in this. Tell me in which blood cancer, in blood malignancy, we use cladribine. I'm sure you have written the answer. Answer is cladribine we use in case of hairy cell leukemia. Now, other symptomatic treatment, because patient has many more problems. For spasticity, we can use tizanidine, and we can also use baclofen. Baclofen is much more commonly used. Baclofen. For urine retention, we use bithanacol, which is a cholinergic drug. For urine incontinence, we use oxybutyrine. For painful neuropathy, there are plenty of drugs, but we can use drug like gabapentin. Then, to increase the walking speed, we use delphamidine. And for optic neuritis, we use again intravenous steroids, methylprednisolone, but recurrence occurs in around 35% cases. So a quick recap of the last minute revision point. For multiple sclerosis, the young ladies 20 to 40 years, neurological deficit disseminated in time and space, monocular blindness due to optic neuritis. In optic neuritis, painful eye movements are there. In the bladder, patient can have incontinence or maybe urgency, maybe urine retention. INO, internuclear ophthalmoplegia, is a characteristic feature. Heat sensitivity is Otto phenomena. Lermit sign is Barber chair sign. Best initial test and the most accurate test is MRI. Treatment for acute attack, steroid or plasma exchange, or for prophylaxis, we can use interferon beta, and large number of other drugs are there. Thank you very much for watching this video.